All right, who'd like to start today?
I can start. I'm probably not going to be here next week because I'm going to be at a conference. I've got a few nice ones I'd like to show.
Yeah.
So I'm going to start with a quickie here from one of my residents. This was from the general, and it's a 43-year-old trauma. It was a PEDS versus motor vehicle was the history, and this was the PEDS. And I think that once you've seen this, it's pretty apparent what it is. This is kind of an Ant Mini, but I think there were a few things that were confusing to the resident that hasn't seen this before. Of course, here you see there's some volume loss on the left side, and there's this abnormal lucency that we see here. And you notice the mediastinum looks a little shifted, the trachea. Of course, the thing that I think helps seal the diagnosis is the absence of a left-sided pulmonary or left-sided aorta and the presence of a right aortic arch. So this is a great look for proximal interruption of the left pulmonary artery, which, of course, whichever side it's on is almost always associated with a contralateral aortic arch. So when it's right pulmonary artery absence, it's harder because you have a normal left arch. But they weren't sure what was going on. They thought maybe there was a pneumothorax there, went ahead and did the CT. You can see this is just the anterior junction line and right lung herniating across. And we see what we expect.
Oh, Travis.
Yeah.
Travis, did you say herniating? Travis.
Sorry.
Mediastinum has rotated.
No, not herniated. Extending across midline to the left, not herniating.
Very good.
Sorry. Not herniating.
Okay.
Yeah, you're correct. It's just all volume loss and rotation from the absence of the pulmonary artery on that side. So, thank you. Precision.
Okay.
Yeah. So proximal interruption of the left pulmonary artery associated with a right-sided aortic arch, numerous collaterals as you see here. So, okay. But just not to be confused with trauma.
This is a great case. I'm going to try to collect this one if I could and use it in a talk about why it's not herniation.
Sure.
So, do I have your permission?
Of course. Yeah, I will. Yeah, this one will be on my website this afternoon. So.
Can Trevor show us the lung window, if you would, so we can see what the left lung parenchyma looks like? Are there?
I think it's going to be busy with transpleural collaterals, and you can see a lot of. I was actually expecting. It looked like on the radiograph there might be a little bit of rib notching, but there's no real enlarged intercostals, at least posteriorly, where you would expect. These are all mediastinal, and there are some small intercostal vessels that you see here. And of course, the pulmonary veins are normal, so this is all arterial. So, yeah.
It does look as if the thing's getting in there from the chest wall, though.
Yeah.
Yeah, that's quite nice.
Now this one is especially for David. And this is one I saw a follow-up yesterday. This is a 66-year-old woman, and this was her radiograph from last year. She's got relatively lucent lungs, especially the mid and lower lung zones. And so she was billed as just COPD, severe emphysema. And so we were just reading a follow-up post-transplant lung the other day, but this is why I always encourage my residents to be curious, because I always like to figure out exactly what's going on. And you see central lobular emphysema in the upper lobes. And then as we scroll down, you see more just diffuse loss of lung parenchyma. There's a lot of large airways, wall thickening, so chronic bronchitis, but it looks more panlobular. And so we went digging in the chart looking for her alpha-1 level, and there was never any mention of alpha-1 antitrypsin deficiency. They just said it was severe COPD. And I could never find the levels, so we looked and checked, and then I was like, well, let's look at the path and see what the explant showed. And the explant showed Talc granulomatosis. So intravascular granulomas, crushed tablets in both lungs. And I think this fits with what David originally described as Ritalin lung, even though we don't know the culprit drug in this case. It's interesting, I think other things that would point towards this, she had a relatively limited smoking history. And I think also the telltale sign is she has Hep C, which she attributed to past drug use, even though she now denies drug use. And so her Hep C is controlled. She's been on one of those super expensive drugs to get her viral load undetected. So Yeah, this is the first one I've seen. I think the other point to make here too, and which I think makes sense, is that she has, you know, a large pulmonary artery and had pulmonary hypertension. I think she actually has a little bit of pulmonary artery atherosclerotic disease, which normally patients with emphysema and just chronic obstructive pulmonary disease don't get severe pulmonary hypertension like you would see with pulmonary arterial hypertension, as you would see with injection. Now, I can't reconcile why her right ventricle is not larger, but I think this is the first path-proven case of Talc granulomatosis, Ritalin lung, mimicking, you know, alpha-1 panacinal emphysema that I've seen.
Very interesting.
Her small pulmonary vascular bed is severely obliterated, resulting in pulmonary hypertension. It's not just morphologic lung disease, but also probably very severe small vessel disease.
Right, and I think that fits. I was looking at David's series from HAR, and at least there were like 9 of the 21 patients you had that had, at least from measurements on CT, enlarged pulmonary arteries, or measurements on CT or radiographs. So that was an unexpected surprise, but that's why I always, you know, keep looking to see what the path actually shows.
Travis, was there any high attenuation material in lymph nodes in that case? Sometimes talc is supposed to end up in nodes.
Yeah.
I didn't see any as when you went by.
No, I don't.
Okay.
So, but that was definitely a surprise.
So they've taken talc out of most tablets. It's still there in some Ritalin preparations, and I think it used to be in methadone and things like that. So it was much more widely used than recently.
Yeah, and some of the excipient lung cases we've had, it's the other binders too, the crospovidone and whatever the other
microcellulose. Yeah.
Yeah. Okay, and then let's see, this one, this is speaking of lung transplant, this is actually a post-transplant case that's interesting. So this is, I always have a soft spot for cystic fibrosis with spontaneous pneumothorax, because this was my first case on the chest section of the oral boards with something like this. So patient with CF, you can see upper lobe volume loss, bronchiectasis, spontaneous pneumothorax. And this was, he underwent lung transplant in the end of October of this year. So it was about 2 months out when I'll show you this final CT. This is his first post-transplant CT, and I'm going to point you to the large airways. They look reasonable, the anastomoses. He's got small effusions. And then I saw this CT right before Christmas and noticed that he had some little centrilobular nodules, mostly in the right lower lobe, and a little bit in the left. And you think some sort of small airways infection. But what really caught my eye was the degree of just irregularity of his large airways, and you can see there's, you know, looks like mucosa that's sloughing off, or some debris, whatever, in the airways. And so I called the pulmonologist. He was actually, other than a little bit of cough, relatively asymptomatic. He didn't have fevers, didn't have an elevated white count, but they were going to wait till after the holidays to bronch him. But based on this finding, bronched him at this time. And this is about 2 months after transplant, and this turned out to be a necrotizing suppurative tracheobronchitis. And it was actually polymicrobial. It grew some rare aspergillus, but also had staph and had Pseudomonas in it. So we've seen cases of ischemia, and I wonder if ischemia drives this, because this tracheobronchitis is one of the like peri-operative or recent post-op within the first 3 months after lung transplant, one of the things that you will see. So I wonder if how much of this is just induced by some sort of ischemia. I don't know, but from what I've read, the limited literature on this, that these patients can be relatively asymptomatic, as he was. He was recently bronchhed within the last week after having been on high-dose antibiotics and antifungals, and his mucosa looks much better. But this is just a reminder, especially in the immediate perioperative period, to always look at the airways and on those first few post-transplant studies.
So Travis, did you say it's staph and Pseudomonas?
Yes.
See, those are the organisms that usually colonize the cystics, and when after their transplant, they still have native trachea with mucosal glands that could be infected with those organisms. So they've got a ready reservoir of both staph and Pseudomonas
Yeah.
to infect their transplant. So, you know, if it's the same organisms that this man had before transplant, they're probably his own organisms.
Probably, and also, and I think that, you know, if you look at we can kind of see the anastomosis right here, and it's like the organisms that were in his own trachea probably, you know, affect the bronchi that he then acquired from the transplant.
Right.
Even especially on the left, you can see that the left main stem bronchus, his left main stem bronchus looks reasonable, and then you start to get this ratty, irregular looking bronchi just beyond that.
Mm-hmm.
Yeah, that's pretty impressive.
Yeah. All right, and then I'm going to show two more quick ones that are related to each other. This is one that I've been holding on to for a while, and I've got a nice companion case to show with it. And this is a patient, you can see in 2017, in May of 2017, he doesn't look all that unremarkable on his radiograph. Maybe in retrospect, you could say that there may be a nodule here. I'll show you on the CT. I mean, it's, you know, this was called normal. I can see why. But he actually underwent an abdomen and pelvis CT for diarrhea and abdominal pain of a few weeks duration. And they noticed on the abdominal CT that he had a bunch of these fuzzy-looking peripheral nodules in both lower lobes. And he also had macroscopic pulmonary emboli somewhere on here, a couple in the right lower, or in the left lower lobe. But that prompted a chest CT the next day, which I saw. And you can see that these fuzzy peripheral nodules, you know, largest one here, certainly look like they could be septic emboli or some sort of hematogenous infection, but he wasn't really that symptomatic from a respiratory standpoint. He was on the internal medicine team. And, you know, the one thing that I noticed when I was looking back at the abdomen and pelvis CT, when I was just comparing, is that his pancreatic duct looked a little dilated, and that he had something here in the body/uncinate of the pancreas, which hadn't been commented on initially. But one of the things that always scares me, especially when patients are asymptomatic and have looks like this, is metastatic disease, especially from GI primaries, because we've seen these kind of fuzzy mixed solid and ground glass nodules in those cases. This guy ended up going home. You know, we had a whole long differential, but he was relatively asymptomatic. They checked ANCA levels, everything was negative. He left AMA and he came back a few months later, and you can see that these nodules are a little bit more solid. Some of them are cystic. They're still there, so they're not infectious. This is that dominant one. And he ended up at this time undergoing EGD and did, in fact, was confirmed to have pancreatic adenocarcinoma. So presumably these were metastases. He actually never got a lung biopsy, and he died a couple months after this study. But this was a sneaky presentation of adenocarcinoma from his pancreas. And I think that especially when patients present with unprovoked pulmonary embolism too, of course, then you have to think about cancer as well. So,
yeah, the pattern of growth is really interesting. Maybe some nephritic growth.
Yeah. And then that one leads me to, will be my final case here. And this one just still shocks the heck out of me. But this is a patient who underwent a Whipple procedure 3 years before this study and had been lost to follow-up and had this bizarre looking, you know, cystic lesion. I'm not going to call it a cyst because it has a wall. And as we've talked about at a few recent conferences, you know, just because the wall is relatively thin certainly doesn't mean it's not cancer. And this one has, you know, some areas where it looks a little bit more nodular than others. She had, during her Whipple, she had just one positive node, so they thought that she was disease-free. And she was lost to follow-up again. We thought this might be a primary lung adenocarcinoma, just given that she hadn't, it would have been 3 years since her Whipple. We didn't have any other imaging. Lost to follow-up again and came back 2 months ago. And now it looks all the world like a primary lung adenocarcinoma, one of these bubbly adenocarcinomas. We were willing to say this was almost certainly going to be, you know, a primary lung, but the oncology team was insistent on biopsy, and we, you know, anecdotally, we don't like to biopsy cavitary things just because of at least the theoretically increased risk of hemorrhage and air embolism with these. but we did biopsy this, and I was 98% sure it was going to come back as a lung primary, and it ended up being metastatic adenocarcinoma from her GI tract. So isolated met, 6 years out, slowly growing. And I guess that's why, even when it looks like primary lung, that's why we biopsy these, because they can, certainly lung or pancreatic is one of the ones that can mimic lung adenocarcinoma.
Very interesting.
Yep.
So,
yep, very much
and
so.
it certainly changes her management. So it was worth the risk of the biopsy. So, all right, Jeff, I will stop there.
Thank you, Travis. All right, who's next?
I can go.
All right.
So Travis, I'm going to show this one first because it complements what you just showed really well. So the morphology of that lesion that you showed was really interesting. And I'm going to show you this patient. And let's go straight to the thin sections. So look at the morphology of the lesions as I scroll down. So here we have two small solid nodules. This one has more lobulated margins. These are cavitated or pseudocavitation, somewhat similar to Travis. This one over there, similarly. Now we see some solid nodules, but also a cheerio or two, and more of the same as we go down. Some of the lesions are larger, and again, similar combination. Here are larger cystic lesions, just like the one Travis showed, exactly, and more of the same. And finally, down here, we get a rather large lesion with lobulated, even spiculated margins. So this, at the time of diagnosis, is metastatic adenocarcinoma of rectum, no prior treatment. So again, it emphasizes that you can definitely get cystic lesions in the context of adenocarcinoma, not just squamous cell. And I think we've all shown cases like this from the GI tract, including pancreas.
Yeah.
I have seen this before with colon cancer, but I think it's probably the most dramatic example of the different morphologies and growth patterns of adenocarcinoma.
And maybe it's just selection bias because we see more adenocarcinoma than squamous cell, but I think that most of the cases of cavitary metastases we see are adenocarcinoma. Sarcomas as well, but I think it's more of, I think our residents still like to say squamous cell first and foremost, but I think that's more like older literature. What do you guys think?
I absolutely agree with you on that. I mean, the majority of squamous cell mets we see are head and neck. And we don't, they seem to, those will cavitate, but even primary lung, if I see a cavitary lung cancer, it's probably an adeno. And I think it's a numbers thing just because the incidence of squam is down so much or adeno's up.
Yeah.
Yeah, there's definitely a spectrum bias there. A very interesting morphology. All right.
I think the other reason is that that your analysis is based on CT, and those statistics appeared back in the plain film days, and it was really much harder to see a lot of these adenocarcinomas. So if you don't see the lesion very well, you can't see that it's cavitated very well either. And they seldom got the path correlation to identify cavities when in those days. So I think that it was selection, and I think our imaging is so much better at showing cavitation or subtle cavitation in these ill-defined lesions of adenocarcinomas.
Is it also just the squamous cells that have been there a lot longer present later as larger lesions on chest radiographs, that we used to see?
Right.
Yeah, interesting. All right, this is a lovely case, very similar to quite a few that I've shown before, but because this is such a nice example of the phenomenon, I thought I would show this one. It's a case of cystic disease, and you can see that the cysts are located in all lobes, and pretty much all of them are well circumscribed. The odd one, if one looks fairly carefully, might have a little bit of residual tissue within the center. I think this one here particularly shows that phenomenon very nicely, and I find that very helpful. So
that superior segment left lower lobe right there too.
Yeah, let's have a look at the other one that shows the same phenomenon. So this one, for example, has a small dot or a little bit of tissue in it. Yeah, oftentimes the more one looks, particularly with thin cuts, the more you see that phenomenon like that. So this association is one that we've seen before, but it's a nice one. So this is a person with multiple myeloma. There is the pathological information. It is a monoclonal lambda. Notice that there's no amyloid, at least in the bone marrow, but interestingly, and I almost missed this when I looked at the record, I found that they had actually biopsied a fat pad, and there is some minimal amyloid deposition. But suffice it to say that this phenomenon is actually not at all surprising. So one can infer that there is deposition in the lung parenchyma of the lambda light chains in this instance, and cystic disease as a consequence of that. So a nice association of cystic lung disease with, in this case, multiple myeloma and lambda light chains. This one is probably the nicest example that I've seen of a patient with calcified tissue, particularly in the anterior mediastinum, as a consequence of remote radiation therapy for Hodgkin lymphoma. I don't know why there's a calcified lesion down there. I wish I had the CTs to see where the disease was, but this is a pretty nice example of particularly florid calcification within treated lymphoma tissue nodes in the anterior mediastinum. And the other finding that goes along with that, if you didn't have that history but were thinking about it, and it's pretty subtle, is that there are pretty subtle symmetric paramediastinal reticular opacities and slight elevation of the hilar that goes along very nicely with radiation fibrosis. And if this is the minor fissure, which I think it probably is, a little upper lobe volume loss. So putting the whole thing together, very nice example of what one may see after radiation therapy treatment of lymphoma.
So Howard, those that anterior lower node that you pointed out is called a diaphragmatic node, and that was a notorious place for recurrence of Hodgkin's disease after radiotherapy because they would shield the heart, and so the dose that was delivered to that area was reduced from what would be optimal, and so Hodgkin's disease would sometimes recur precisely where you're seeing this node.
Okay. Well, I don't know whether she received concurrent radiation chemotherapy, but I think the treatment was many decades ago, so perhaps not, but I don't know that. This case I'm going to show you next will be a case that I think Travis will recognize immediately because he showed a case, if I'm not mistaken, exactly like this a couple months ago only. So this is the scout tropogram. The patient came with the diagnosis. I don't have a chest radiograph, but the history is cardiac arrest and resuscitation and intubation in the field. So Travis, are you still there?
Yeah.
Okay.
I see the endotracheal balloon looks like it might be a little overinflated there. And I don't know if there's a little pneumomediastinum there. There's also a line or some sort of object overlying the right internal jugular region, but that just may be external.
It's that there. Sorry, I don't know what I made that a key image, but that's exactly the finding. Let me show you the CT now. And so far, so good until we get to there.
Wow.
Yep. That's a large tear, traumatic perforation of the trachea, pneumomediastinum. So there you go. I think this is nearly identical to the case that you showed.
Yeah, and
Back.
and even the presentation of being intubated in the field was one of the, I think I've seen 2 in the last year or so. But it's just amazing too how little pneumomediastinum there is.
Yeah, you're right. It's surprising. A very modest amount. I presume the rest of what's in the lungs is perhaps aspiration of blood and the like that went down there.
When you guys are reading ICU radiographs, do you call on what you suspect are overinflated balloon cuffs, or do you have a number? Because I think that I've read like it shouldn't be more than twice the diameter of the endotracheal, the tube itself, but I don't know.
Called it if it looks like it distorts the shape of the trachea, because I mean those cartilaginous rings should be nice and straight. So if I see a bulge, like in this case, I would definitely question it. But
yeah, very dramatic. And here is the description of the surgery. They fixed that. Okay, those are my cases, Jeff.
all righty, thanks. David, do you have cases this week?
I have a couple.
All right, I'll give you control.
So here's a young guy with, I think, presented with some shortness of breath and has this abnormality here on the left, consisting partly of pleural effusion, but probably something more, and the mediastinum has gone off to the right. And this turns out to be a very large tumor here. It's pretty vascular. It's got lots of blood vessels in it. And it's got this great inhomogeneity, probably reflecting necrosis. And then there's pleural effusion, and there are some tumor nodules. And this is a young guy, I think, probably in his teens at this point. I'll check on his precise age. And it's squishing his pulmonary artery here. It's pushing pretty hard on the mediastinum. This was called a mediastinal mass, and it could well be. It's really hard when it's so large for me to tell where it originates, but the fact that it seems to be pressing on the pulmonary artery so strongly implies it might be in that mediastinal compartment. And this was a Ewing sarcoma in this young guy. And he subsequently, over the years, this was a few years ago, has developed recurrence and metastasis, and he is not doing very well. But this was the original presentation of a very large tumor. So I remember these Ewing tumors are often very large, present in young people. The fact that they're so large implies that they might have slow growth, to get to be the size at the time of diagnosis. But this was a pretty bad one. There was a PET scan shortly after this that I've not been able to anonymize to show you guys, but there was actually fairly little uptake in this. For one thing, there were big areas, I think corresponding to the necrosis, where there was no uptake, but the uptake in other parts of it was fairly modest. And, again, that would imply that it might be a slow growing, not that metabolically active thing. Especially, since it got to be so big before he came in, slow growth is a good explanation for that sort of indolent presentation. So Ewing sarcoma, it's hard to tell if it's mediastinal origin. It was never resected. There was no operation for it. It was treated with chemotherapy. And so we don't know precisely where it started in the thorax. They often present as pleural tumors.
So David, last week, if you recall, I showed that peripheral neural ectodermal tumor, which is what's in the same family, and that one was centered in the mediastinum. I think you're right. This one is extramediastinal, which that's where I've seen most of them in older kids, younger adults, is pleural or chest wall and not mediastinal. But the one we had was pure mediastinal, which is very, very rare place.
But you like this one as being non-mediastinal, is that right?
Yeah, I think I wonder if I'm just looking at what you've shown, but I wonder if it's pushing. It seems to be pushing all the mediastinal stuff out of the way rather than the one I had kind of pushed everything away from it in all directions.
Uh-huh.
They tend to wrap themselves around. They tend to be very hypervascular, but not necessarily directly invade everything. So.
Yeah, I think it's really hard to tell where this thing came from. But so do you think medial pleural origin then? If you're
Or maybe, yeah. I mean, yeah. And
okay.
they're not very treatment sensitive to radiation, if I recall, at least, because the one I showed was presented to me by a surgeon who was a little not interested in taking it out because of its location, but was told by oncology there weren't a lot of great choices for it.
Yeah, he did get chemotherapy, and then I think he had some sort of selective palliative radiation to a few sites or something like that, but radiation was not the main therapy.
It is interesting that he's got quite a few pleural-based lesions, as you indicated, but they're rather impressive, aren't they? At least the one down there.
Yeah, they're very large, and I think there's a bunch of them here sitting on top of the diaphragm. Yeah. Okay. So a Ewing sarcoma in a young person, and then this one is really kind of a plea for help. This is another young person here, who I think is currently in his 20s, and he carries a diagnosis of congenital pulmonary arterial hypertension. Never had any congenital heart disease that we know of. And he's got this dramatic finding here of lots of septal lines. And then if we go back and look at his pulmonary arteries, you can see his pulmonary artery indeed is large, about 3 times the size of his aorta that's going along with his pulmonary hypertension. And then he's got the abnormal lung, seems to have all these holes in the lung. The records are very sparse on this person. He was evidently worked up in Denver and stuff like that, and he recently arrived out here and brought a bunch of records with him and stuff like that. It's been a little hard to digest these medical records and know exactly what has been done. There's been no lung biopsy on this person. So this pattern here suggests that he might have pulmonary veno-occlusive disease.
Yeah, that's what it looks like.
Yeah.
Yep.
And I was unaware that is a diagnosis that's sometimes made in the pediatric population. I was talking to Jonathan Swanson this morning, our pediatric radiologist, and he said that he works with there's a pulmonary hypertension specialist at Children's Hospital who comes to him and wants him to go over CT scans and other imaging to determine whether the child has veno-occlusive disease. So I was not aware that this diagnosis could be made in that population. But the other finding that I wanted to ask you guys about here is the mediastinal tissue here. There's a lot of stuff that looks like amorphous lymphadenopathy, and you can see it's mediastinal. It's in lots of different locations here, and it is also hilar. I think we can barely see that there's tissue that's separate from the vessels involved in these highlights. Non-contrast study making it a little weak, but that's the case. So I've seen a fair amount of amorphous lymphadenopathy in people with lung edema before, but this is really much more striking than that. And I start to wonder, could this fellow really have something like some infiltrative disease like Niemann-Pick or something like that? So could this really be that he's got tissue around his vessels rather than a primary vascular problem? And I looked up Niemann-Pick and pulmonary hypertension, and Niemann-Pick is one of the things, and Gaucher's disease is one of the things that can lead to pulmonary hypertension. Does that make sense to you guys, or do you think this lymphadenopathy is just the fact that he's got a fair amount of lung edema on board because of his post-capillary obstruction, presumably, and VOD? What do you think?
I still like this for PVOD, and with all the venous obstruction, the lymphatics are having to work extra hard to clear liquid from the lungs. So you get this because he's got the other findings. He has a small left atrium. He has small pleural effusions. He's got pericardial effusion. The right heart chambers are big. You know, I've seen Niemann-Pick, and it can present as diffuse septal thickening, but I don't recall. I've not seen a case of pulmonary hypertension. And then the other thing that we didn't talk about yet, that I'm not sure if this is lymphangiectasia, congenital lymphangiectasia. I don't know if that would give you pulmonary hypertension, but I know I showed a case years ago, and it looks like PVOD in the lungs, and they would have very large, dilated, engorged mediastinal and hilar lymphatics.
Right. Yeah, and so that actually came up in our discussion this morning too, with Jonathan Swanson, and I was kind of wondering about that. So I was looking for dilation of lymphatics in the paraspinal tissue here, and you know, there are a few little places where there could be some extra lymphatic tissue down there. I mean, there are lots of little dots, but nothing that's clearly a dilated thoracic duct or other major lymphatic. And against Niemann-Pick, for instance, is the fact that he doesn't have splenomegaly.
Right. And now one of the very first cases I showed on this conference back in like whatever 2012 or 2013 was a young patient that looked somewhat like this, and it actually ended up being chronic alveolar proteinosis when they did a surgical lung biopsy. Again, I don't know if they had pulmonary hypertension, but it was because I was thinking some sort of deposition. Mm-hmm. And yeah, it was more, I guess it was more septal thickening than this, but it was that would be the other thing, I guess.
Okay. So are you guys, should we let it go with PVOD, or do you think, should we suggest that they get some tissue and see if there's a lymphatic abnormality in that mediastinal tissue, or what do you think?
Depends. I mean, if that's pulmonary hypertension, he's going to be a pretty risky biopsy. I don't know what his pressures are, but those lungs look angry. But because it would have to be a surgical biopsy. I know it's really challenging to bronch them and get the diagnosis. But you know, and I don't know if there's treatment for any of them.
Okay.
Well, the other question I have, Dave, is how long has he had this? Because at least what my experience is, the patients with PVOD tend to present rather quickly and decline rather quickly, as opposed to drawn out over years.
He had a diagnosis of pulmonary hypertension made in infancy. Goes way.
Yeah, I think if they could get tissue safely, there's enough uncertainty.
Yeah.
Yes, I think so, true.
Yeah.
So you go for lung and mediastinum, do you think?
No, I wouldn't touch the mediastinum because I don't think it's, well, you could try. I mean, they could try like an EBUS, but.
Well, no, I'm talking about doing it mediastinoscopically or something like that. There's a lot of stuff up here.
I think you could get away with the VATS.
Okay.
And just do the lung, and then the mediastinums can be related to whatever the lung abnormality is.
I don't think I've ever seen this much lymphadenopathy in the setting of elevated left-sided pressures backing up. I don't know, Jeff, have you seen this much in PVOD or just left heart failure?
PVOD does cause lymphadenopathy,
Yeah.
and again,
and Chris brought up,
so I don't know.
David, Chris also threw out pulmonary lymphatic perfusion syndrome.
That's a new one.
Yeah, we had a case where it's just, yeah, it's along that whole lymphangitic, I mean, sorry, not the lymphangiectasia, the lymphangiomatosis, it's sort of on this lymphatic thing, but they just get like excessive drainage of lymphatics into the lungs. We had a case here, a guy was coughing up, like intermittently would get these things in his lung, it was kind of whitish. And then when they did the lymphangiogram, you could see all these branch vessels going into the lungs. But if I recall, that case was patchy, but it's just another thought to add into the sort of the differential diagnosis.
Oh, pulmonary lymphatic
perfusion syndrome.
Wow. Okay.
I'll have to dig up our case and show it again because we had.
Did your case have plastic bronchitis?
Yeah, or something similar along. I think it was more liquid plastic bronchitis.
Wow.
Okay. Well, thanks for the consultation on this case,
guys.
Yeah,
it's a great case. My bet's on PVOD, just given what I've seen.
But your point of the chronicity of it is certainly a good one.
Yeah.
Yeah, that's
Yeah.
the only thing that's just, it's funny, but maybe in children it's a different disease. I can ask, tomorrow I can ask our pulmonary hypertension expert what his experience is. I know he occasionally sees some kids.
Okay. Thanks, guys. Appreciate it.
Good case.
Back to you.
All right. Okay, well, I got a good one to go with Travis's case. Where did I put it? Hold on. Hopefully I loaded it up. I will be mad if I didn't. Darn it, did I not load it up? Bummer. Well, I'll have to do it next week, but I got some other good ones. Okay, so let's resume here. So this is a case, this is a neat case, and this is just a great teaching case on pleural tumors. We've had some nice examples in our just looking at some cases as a group of some of my colleagues looking at pleural things because the pleura is sneaky. So this is a guy, young guy, he's 32, carries a diagnosis of osteosarcoma that's been treated, resected, and chemo, and then on surveillance. And these were all from the outside, and I'm going to try to get them up in order. So this was the first scan. No, that's not the one I want to show. I need to go back. I'm sorry, my dates are off here. Yeah, that's the first one. And then he had a subsequent scan, which is loading, and then another one, and then the final one. Okay, so left to right, or I guess this is the oldest one here. And at that time, the only abnormality, which I'm showing in retrospect, and I'll blow it up for everyone, is this little tiny bump with little calcium on the pleura. Now, to be honest, I see this all the time, because we have histo here, and occasionally you get it in a pulmonary lymph node, and they like to sit on the pleural surfaces. So let's see. So now we jump ahead 2 months later, and that little nodule you can see has gotten bigger. And still, if I just saw this with no history on a routine CT, I would ignore that as it's even triangular as calcification in a pulmonary lymph node related to histoplasmosis. So here we are now 2 months after that scan, and I'll bring it back down. We'll see that that abnormality is continuing to enlarge. And then on the most recent scan, it's clearly not a lymph node. And so I don't have tissue yet, but I don't think anyone would argue this is not an osteosarcoma metastasis. And we've seen pleural cases. Usually they're very exuberant with just a rind of neoplastic bone, but this is just the beginning. And this is moving rather slowly. I mean, it's growing fast, but this thing has been percolating for a while. And I think his original diagnosis was a year before this CT when it wasn't present at all. Interestingly, he does, let me just close some of these out. He does have a calcified lung nodule, which, again, I see on just about every single CT to the point I don't mention them. But in these sarcoma cases, it's the one time I will mention them. And, I saw this here, and I was like, maybe this is a lung nodule, a metastasis, but this has not changed. And when I went way back to his original staging CT, there it was, and it looks exactly the same. So it's important when osteosarcomas, especially if you live in an area with granulomatous fungal infections, to sort of take account of all those calcifications to make sure they're not new. And that pleura is just so sneaky. And this is, this one's hard because it's right down in the recess or at the dome. And so sometimes coronals and sagittals can be more helpful.
Yeah, and since we're talking about Mets today, like osteosarcoma in particular was one of the original ones to be described presenting with spontaneous pneumothoraces from pleural involvement. Right.
Okay, so this is a case sent to me from folks at the University of Cincinnati because they had never seen a case like this and they were curious. And I've seen this, and I know we've all seen it, but I told them I'd show it on the webinar. Maybe we have some insight. So this is a 60-ish-year-old female, non-smoker, works like in an office job, had a mother die of lung cancer or a family member die of lung cancer, but that person was a smoker and presented with weight loss and a little bit of shortness of breath. This was the radiograph that was done at that time. And then I have a CT scan to go along with it. It's a little bit later, but this has been sort of a chronic process. And I'll show you this appearance.
Holy moly. That's 2 years after that radiograph?
Yeah.
Wow.
Yeah. So this sort of nodular, confluent nodules that look, some are very discrete and some are all blurring together, but I don't have the sharp recon. And this one's a little cystic here, but I've seen several cases of this, of adenocarcinoma, sort of just the old mucinous type. Turns out this one wasn't mucinous, but it was micropapillary, which is interesting because that's the one that's associated with a very poor prognosis and aggressive behavior. So I wonder if something's mutated in it. But this is that infiltrative, used to be called like pneumonic BAC. But I wonder if that was the original site there. You got this large blob, but when I see these discrete lesions with a ground glass halo but a very sharp margin, I always think of adenocarcinoma. I also have a case of pancreatic metastases that looks just like this. And interesting, they did a liquid biopsy, and this is EGFR mutation positive, which would we see non-smoker female.
Yeah, and EGFR mutation positive ones are more associated with a diffuse presentation as well.
Right. So.
And this one's interesting because some of it almost looks perilobular, like you see with organizing pneumonia sometimes. Of course, the key here is that there's nodules, which you certainly wouldn't associate with organizing pneumonia.
And also, they have very sharp margins, which I don't like. Organizing pneumonia, because if you just think of it pathologically, it's going to have fuzzy margins because you're going to have involved alveolar ducts and alveoli and then spared ones not too far away, whereas this tumor's growing in a nice straight line. I mean, look how sharp these interfaces are, even aside from the fissure, but even here. So yeah, this was just a cool case. And there is a radiograph from 2008, and in retrospect, I don't think I would see I don't see anything in there, at least on that image at the time. So this developed and it's just sort of been smoldering along, and weird adenocarcinoma. This is just this is one of the best examples, and this is something I see a lot, and I get frustrated when patients I see people have had this resected, usually somewhere else. Luckily, this one was calcified, but this shows the classic granulomatous appearance of histoplasmosis. And cocci I've seen look like this, where you see the dominant nodule, and you can see it's got calcium along the wall, but it has all these little satellites, and you can follow them really nicely, and I'll show the MIPS along the lymphatics all the way, and you see little calcifications all the way towards the hilum, and then you have the calcified hilar node with the eggshell, and then the 4R node, which of course is the secondary drainage point, and a little bit in the subcrinal node, which is sort of the sewer of the lung. But the MIPS, I think, are just fantastic. And so even when I see these on non-calcified nodules, I'm very confident in calling histo, or at least granulomatous infection, specifically fungus. I've seen cocci do this as well. Never blasto, but it really shows the sort of the pathophysiology of histoplasmosis. It's, you inhale the spore, converts to a yeast, it sets up shop in the periphery of the lung, and quickly there's an immunologic response, and that's why a majority of patients are asymptomatic. But those macrophages that are gobbling up the fungus and the other cells then, of course, get into the lymphatic system to clear out of the lung, and along the way you get granulomas forming, and then those, over time, those can calcify. And so if you feel very confident when you see and I'll dig that case up of the non-calcified one that is now surgically proven. What typically happens is they're seen on a radiograph, seen elsewhere. Someone gets a CT and then a PET, and of course, histo is quite FDG avid. The lymph nodes are even hotter than the nodule, and then they get sent to someone to biopsy it or take it out. Back along this, so you see it draining along there, and when I see that satellite pattern, the lymphatic drainage, I feel very confident in calling it granulomatous, and at least watching it rather than jumping to try to resect it or something, do more invasive or expensive tests.
Really nice example. There are lots of little granulomas in the surrounding lung too, which is interesting.
It's and you can just follow it along. But that's just one of the best examples I've ever seen of that. We see it quite a bit, but I've never had that many little calcifications. This is nothing new, but it's just a beautiful example, and I've got a nice echo. This patient has a big mass in the left atrium, and even on the CT, you can see this is an outside scan, and I don't know how fast what their pitch was, but clearly it's moving slowly enough that you can see the mass prolapse through the mitral valve into the left ventricle, And based on its location, this is almost certainly going to be myxoma, which this ended up being. But I thought the echo was just gorgeous. So a functional mitral stenosis here. You can see there's really, it almost pushes the mitral valve leaflets open when the left atrium is contracting there. So, and then, you know, it's got that lower echogenicity with some solid components you often see, but just a classic. I like that one. Unfortunately, there's no radiograph, but it wouldn't show anything much anyway, except maybe some findings of mitral valve. And then
any edema in the lung, just because there's small effusions, which is expected or not surprising.
right. Well, let's take a look.
Any hint of a septal line or peribronchial fluid tuff or two, or perhaps not?
Not enough to call.
Not really.
Trace effusion. Yeah. So apparently enough was getting through this. All right. And then this last case here, let's see if I can find it. This is a patient who had had an aortic valve prosthesis placed and was having abnormal echo. And you can see on the echo, I mean on the CT here, and I've got some different images, that clearly there's this abnormal collection just posterior. And I think I've got some reformats. If not, I can make them real quickly. Yeah, here we go. Here we got a multiple plane, but you can see there's this abnormal collection right here. So clearly looks like a perivalvular leak. And next thing to look at is if you look at where the struts of the valve are, they're actually not at the annulus there. They're sitting above at the sinuses of Valsalva. And I'll go back to some axial images. So this is a floating prosthesis. It's sort of dehisced. And so this patient developed an aortic insufficiency because the valve should be down here at the valve plane, and instead it's sitting way up here.
Right, and that's the typical location of the dehiscence at the mitral aortic intervalvular fibrosa, the part of the annulus that has the least vascularity and is most susceptible to injury or infection.
Oh, okay, that's good to know.
Yeah, that posterior portion, and that's why if you ever see anything between the aorta and the left atrium like that, you know that there's something going on.
Right. And I think you guys remember I showed a case, I think it was over the summer, of the massive perivalvular leak that was missed because it looked like the left atrium. It was so big, but it was exactly in that location.
Yep, and we had one here as well. It's like a double left atrium.
Yeah. So this had to, of course, be fixed. But just a really nice example of a dehisced valve with a perivalvular leak. And so, all right, well, that's what I have for the week. I have a good transplant case, but I somehow misplaced it. It's probably, but anyway, I'll show it next week because it's a nice companion case to your airway case, Travis.
Excellent, thank you.
All right, great case, everybody.
All right, guys, take care.
All right, bye.
Thank you. Bye, everyone.